Thank you very much. Thanks, Dr. Spencer and the CVI for the invitation. All right, so now time for the intellectual part of the session is done. Now the plumbers take over, and I'm one of the plumbers, and we'll talk about it. So, indications, obviously, patient has to be symptomatic. If you want to treat the patients with central venous occlusion, the May-Thurner, central venous occlusion in patients with chronic venous insufficiency, what has been talked about. Post-thrombotic patients with central venous occlusion, and this is an evolving area. How deep, how much common femoral, below the common femoral, this is all evolving. The iliacs and the IVC are settled, we need to do that. Below that level, it is an evolving area. Pelvic venous disorders, things like deep venous reflux in the pelvis, what used to be called pelvic congestion in the setting of venous occlusion, obstruction of the cava, obviously, renal vein compression, the nutcracker syndrome. Now, special considerations, we're not going to talk about these, of course. The adolescent and pediatric age group, very different type of pathology, very different natural history. We need to stay very cognizant that they don't behave the same way, so it's a very different group. We won't have time to talk about it. And then the splanchnic venous disorders. This is an hour talk by itself on how we recanalize some of these chronically occluded splanchnic venous system. So, what constitutes obstruction? Obviously, it has been talked about in the literature. Pressure gradient, a presence of collateral, 50% reduction, either cross-sectional area or diameter. Remember, the pressure gradient measurement in recombinant patient is unreliable, very hard to measure. Collaterals can be misleading, and this 50% threshold, although we all use it, is really not been validated. So what constitutes obstruction remains to be validated and defined more precisely. But right now, it's one of those things when you see it, you recognize it, sort of thing. All right, now let's talk about all of these in the context of a case. And the reason I show this particular case, because although this was done a couple of years ago, I did it myself, I made some mistakes. Still, all of us can make mistakes, but I can't believe that I would make a mistake, but of course I do. And I'll tell you why, and that was in the technical portion of this thing that made a mistake. So 41-year-old, history of DVT, so on and so forth, as you can see, typical of these patients. And the patient had a CAT scan. As you can see, the IVC is missing. Right? There's no IVC. Well, actually, there is. Remember that I'll just make a quick comment on this IVC. Infrarenal IVC, embryologically, comes together as a result of 5 different processes. So for the infrarenal IVC to be a genetic or absent congenitally, 5 things have to go wrong at the same time. So if you see something like this in a patient infrarenal IVC, it's not because it was atretic or absent at birth. It's almost always because of clot. And suprarenal and intrahepatic, no, that's different. All right, as you can see, again, up and down, you can see that there's the completely scarred down atretic IVC because of clot. So, and here's what things look like, and here's what, all the collaterals around here. And most of these patients, obviously, decompress through the pelvic veins, which abundantly communicate with the splanchnic venous system, and they decompress into the portal system, or they go into the paralumbar plexus. And here's what it looked like, both the left side, and then this is the both sides. So we have some room to work with. Some of the iliacs are open, and everything on top is occluded. The recanalization is really not that difficult in these patients. We take bilateral femoral access in these patients. You make sure your access is at the point that you have some working room with your sheaths, because the stents need to come into an area where you have good inflow. Typically we start with hydrophilic wires and so on and so forth. Nothing unusual about those. And you need multiple views. If you're going IVC or even iliac veins, I highly recommend to work in multiple views. Otherwise, you're going to find yourself in places that you don't belong. And be cognizant of the communications with the epidural and vertebral venous plexus on both sides. These can cause to disasters. Thankfully, they're uncommon, but they can cause to disasters. And then you go for it. So typical here with femoral access, we are, this is a coaxial system, hydrophilic wire and catheter going up, and you can see I am in an oblique position. And then the next, we make from here all the way up to about the renals, and you can see here we go renals, and right about there we got stuck. Okay, so now we have to come up and see what's going on. And this so far looks good. Let's go to the next slide. Here we go. Now when we inject, this is where we go into those plethora of collaterals here. But thankfully, it looks like it's reconstituting right about this neighborhood here, right there. And so we now have a little bit more to go. Again, chronic occlusions, and you work through it the way we always work through it, sometimes with force, sometimes with a little bit less so, and we make it up there, and now we come from the other side, and you have to do the same thing. Now, from the contralateral side, you recanalize, and sometimes these things are not in the same channel, and I want to caution you, looks like although we're together here and we're angioplasting, and looks like these guys are okay, but note the two balloons here are separated, okay? So, and then when we do a kissing balloon up here, they're twisted around each other. So that, what I want to bring up to you is this. If you look at that IVC right there and magnify it, typically there are microchannels through these things. And it is quite possible that your wires from two different sides, two legs, go in different channels. They may not be in the same channel. Now, what does that mean? You'll find out in a second what that means, because that's exactly what happened. And here's the IVS after balloon angioplasty. There are two different channels. So that will obviously dictate your stenting technique from this point. If you're in two different channels and you recognize it, you either have to give up one of them and get in the same channel, or you have to create a double barrel cava, which is really not what we want to do. And so I put a single stent up there. We gave up one of the wires and came at the bottom and went into the stent. So one of the channels got stented, and the other one we come back. As you can see, I'm pulling back. I'm giving up the wire right here. We gave up access from one of the legs, came back and tried to get back, and we got into the stent. And obviously, you want to confirm that with the IVS. And then we said, okay, fine, we did that. And then the rest of it, what I shouldn't have done, and here's the mistake, that I created the double barrel cava. What I should have done is continue that same thing, come with a single large stent all the way down here, and then go from the opposite leg and do the same thing into a single stent and create a kissing stent down at the bottom into a single stent at the cava. What we're talking about is this configuration, and not this. This, in the venous setting, in my opinion, is suboptimal. Sometimes you have to do it, but sometimes you just get lazy like I did in this case. And this is what you want to do. Please don't do that in terms of fenestrated stents. All right, so did our thing, and the whole thing is thrombosed right in front of my eyes because of that situation, and this is why I want to show you the IVS, two different channels, one completely compressed, like that. And here's the CT scan on the table. One completely compressed. Here now you can see one of the disadvantages or problems with double barrels. Okay, I'll just save you all the hassles of what we did, reinforced all that sort of thing to get this thing going. And here's the IVS. Finally got our two channels, but took 2-3 hours extra that I could have saved by just going into a single barrel and get this sort of thing. All right. So in conclusion, when you want to obviously do it in symptomatic patients, how sometimes easy, sometimes not, and you saw one of those things that was a not. Thank you very much.